Assalamu alaikum. Our lecture today is labor. بالبداية طبعا رمضان كريم وكل عام وأنتم بخير، وتقبل الله أعمالكم وأعمالنا جميعا، ونسأل الله تعالى في هذا الشهر الفضيل أن يمن علينا بنعمة السلامة، وأن يزيل هذه الغمة عن هذه الأمة. Now we start by the first stage of labor. This is the contents of our lecture. The objectives of this lecture: the student must know the definition of stages of labor, and must know the diagnosis of stages of labor, must know the management of stages of labor, and must know the partogram. Introduction. Now we will define the labor. What is the labor? A labor is a uterine contractions resulting in a progressive dilatation and effacement of the cervix, and accompanied by descent and expulsion of the fetus. الabnormal labor هو failure to progress regardless this uterine contractions and all. Approximately 20% of labor involve dystocia. طبعا dystocia راح تاخذوها موضوع ثاني ومحاضرة أخرى. What are the stages of labor? Normal labor divided into 4 stages. The first stage, which is the time from the onset of labor until complete cervical dilatation. Second stage of labor, it is a time from complete cervical dilatation to the expulsion of the fetus. Third stage, it is a time from expulsion of the fetus to the expulsion of the placenta. And nowadays we added to the 3 stages of labor the 4th stage of labor, which is the first postpartum hour, which is important regarding events may happen like postpartum hemorrhage. Okay? In the stages of labor we divided into 4 stages like this. The first stage is further subdivided into latent and active phase, and the active phase subdivided into 3 additional phases, which is the accelerated phase, phase of maximum slope, and deceleration phase. Latent phase. What is the latent phase? The existence of latent phase and sub-phases of active labor are somewhat controversial. Latent phase is typically characterized by mild, infrequent, irregular contractions with gradual changes in the cervical dilatation and usually less than 1 centimeter per hour with effacement. So, the latent phase duration will be 6.4 hours in nulliparous women, and it is 4.8 hours in multiparous women when it is normal. When it is abnormal, it's about 20 hours in nulliparous women and 14 hours in multiparous women. This duration, it's not influenced by the maternal age, birth weight, or obstetrical abnormalities. Other phase in the first stage of labor, we have an active phase. This begins at 3 to 4 centimeters when the cervical dilatation is bloated against the time, and this is the beginning of the active phase. It's characterized by painful contractions of increasing in frequency, intensity, and durations, and accompanied by more rapid cervical change, usually more than 1 centimeter per hour. The first stage of labor, this is the Friedman's curve showing phase of maximum slope. This is the latent phase. Then after that we will shifting into the active phase, which is subdivided further into 3 other phases. And this is the cervical dilatation, and this is the time. And this is the cares for abnormal labor. We will discuss later in the dystocia. Now you must know just the normal curve in order to understand the other abnormal curves in other dystocia of labor. Diagnosis. The diagnosis of labor is very important in order to know whether the patient needs admission or not. The determination of whether a woman is in labor is made within 1 hour of admission. Diagnosis of labor is made only when painful contractions are accompanied by any one of the following: either bloody show, rupture of membranes, full cervical effacement, and the cervical dilatation is not a part of the criteria. When the patient meets the criteria within 1 hour of admission, we will admit her to the labor unit. When it does not or didn't meet the criteria, we will admit her to the antenatal ward, and and after rest and observation until next day. Yani she's still in the antenatal ward for at least 24 hours, and after that we will check her again, and if there is no diagnosis of labor, we will discharge her if labor has not begun. Then everyone coming with history of labor, either diagnosed as a labor and enter them into labor room, or not diagnosed as a labor and will still or stay in the hospital for at least 24 hours, and then we will check her again and discharge if there is no labor. The correct diagnosis of labor is considered to be the single most important determination in the management of labor, because an incorrect diagnosis of active labor will lead to inappropriate intervention and an increased likelihood of cesarean section. Okay, you understand? Then the patient, if she is in active labor, we will admit her. If she is in the latent phase, or if she is in the active phase, we will admit her. If she is in the latent phase, we will does not admit her. We will check her again and then discharge her. And then the patient must enter to the hospital when she is in active phase in order to prevent an abnormal or an early management, and may lead to cesarean delivery, early interference. Management on admission. Number 1, patient preparation. There is no evidence that routine enema or perineal shaving is beneficial. A urinary catheter is not necessary unless the woman is unable to void, but she should be encouraged to empty her bladder regularly, as a full bladder can impede fetal descent. Fluids and oral intake. There is no consensus on acceptable maternal oral intake during uncomplicated labor. Other preparation: placement of an intravenous line or hope lock at the time of admission is recommended. Hope lock mean 2 IV line. Internationally, one randomized trial found that women who received intravenous hydration of at about 250 ml per hour had fewer labors persisting for over 12 hours and less need for oxytocin augmentation than those who received 125 ml per hour. Then the hydration is important as the labor progress, and the need for oxytocin will be less when the hydration is applied. Other part of the preparation in the management of on admission antibiotic prophylaxis in some centers to prevent early onset neonatal infection is appropriate in appropriate patients. The agents of choice is intravenous penicillin. A minimum of 4 hours of intrapartum therapy has been recommended prior to delivery. Because in outside centers in the developed country, there is a screening for streptococcal infection. When the streptococcal infection is positive, they will start, when she's starting labor, they will start an intravenous penicillin in order to prevent neonatal infection and sepsis. Although normal labor and vaginal delivery is not an indication for prophylaxis against infective endocarditis, some centers generally administer antibiotic prophylaxis during labor to pregnant women with underlying valvular heart disease. And then we must give an antibiotic for the high-risk women for streptococcal infection in order to prevent neonatal sepsis, and may be used to prevent postpartum endocarditis and valvular heart disease. Other part in the management: how can we monitor the patient in labor, or monitor pregnant women in labor? All pregnant women require surveillance. For example, monitoring of the vital signs and fetal heart rate. Since 20 to 25% of all perinatal morbidity and mortality occurs in pregnancies with no underlying risk factors for adverse outcome. That's why we need to monitor the pregnant woman, her vital signs and her fetal heart rate. Assessment of the quality of the uterine contractions and cervical examinations are repeated at appropriate intervals to follow the progress of labor. And how can we follow the cervical dilatation and uterine contractions? Cervical examination should be kept to a minimum to avoid promoting intra-amniotic infections, and in general, vaginal examination are performed, number 1, on admission, at 1 to 4 hours interval in the first stage of labor, and at 1 hour interval in the second stage of labor, when ruptured membrane to evaluate the cord prolapse, when there is prior to intrapartum administration of analgesia, when there is when the parturinet feels the urge to push, when we see the patient try or she has urge to push, to determine whether the cervix is fully dilated or not, and if the heart rate is false, to evaluate the conditions such as cord prolapse or uterine rupture. The result can be noted or plotted on the partogram. Active management of labor. It refers to active control rather than passive observation over the course of labor by the obstetrical providers. It includes 3 essential elements. Number 1, careful diagnosis of labor, which is more important, by strict criteria, we mention it. Number 2, constant monitoring of labor with specific standards for normal progression. Number 3, prompt intervention, for example, amniotomy, high-dose oxytocin, according to the established guidelines if progress is unsatisfactory. And then these are 3 main elements essential for active management of labor. The active management of labor is generally limited to the women who meet the following criteria. Number 1, nulliparous women. Number 2, term pregnancy. Number 3, single-litten infant in cephalic presentation. Number 4, no pregnancy complication. And number 5, experiencing spontaneous onset of labor. And then these 4 elements needed in order to apply the active management of labor for them. Nulliparous labor tend to be more subject to failure to progress That's why administration of oxytocin, sometimes at high doses, is one of the interventions involved in active management, and this is safe in newly gravid women, since the newly gravid uterus is virtually immune to rupture except as a result of manipulation or previous surgery. And that's why when we use an oxytocin in nulliparous women, we have in the safe side, because there is no risk of rupture except in women who have manipulative delivery or have previous surgical interference to the uterine wall. Active management of labor. Recommendation on routine amniotomy. إذا number 1 بالactive management using of oxytocin. Number 2 هو الامنيوتومي. There is a limited evidence showed no substantial benefit for early amniotomy and routine use of oxytocin compared with conservative management of labor. In normally progressing labor, amniotomy should not be performed routinely. Combined early amniotomy with the use of oxytocin should not be used routinely. إذا لا الامنيوتومي نحتاجه ولا الأكسيتوسين إذا normal progressing labor. Intervention with amniotomy and or high dose oxytocin are initiated if progress does not proceed according to the defined standards. وقلنا أكثر شيء نحتاجه وين بالبرايمري جرافيد، هم دائما عندهم مشكلة اليوتراين contractions. Rupture of fetal membranes provide information about the fetal status, but does not appear to significantly accelerate labor. In the Dubin protocol, rupture must be performed before treatment with oxytocin, which is administered only in the presence of clear amniotic fluid. إذن هاي الفكرة إنه sometimes إحنا ما نقدر نعطي oxytocin إذا ما مسوي rupture membrane أو amniotomy. ليش؟ لأن ما راح نقدر نحدد الفيتال status، نحدده according to the color of the liquor. When it is clear liquor, that this means the baby or the fetus is not at risk. That's why we can add the oxytocin to the woman or give her oxytocin. And if the membranes are ruptured when there is polyhydramnios or an engaged fetal presenting part, it's prudent to use a small gauge needle rather than hook to puncture the fetal membranes in one or more places, and to perform the procedure in the operating room. This called control amniotomy permits emergency cesarean section delivery or cesarean delivery in the event of an umbilical cord prolapse. But that's why when the head is not engaged and the membrane is collecting, we use this method for the amniotomy, which is called controlled amniotomy, in order to prevent cord prolapse. But every things we prepared for emergency cesarean delivery if the cord will be prolapsed. Routine amniotomy should not be performed in women with active hepatitis B and C or HIV in order to minimize exposure of the fetus to ascending infections. إذا mother عندها hepatitis B, C أو HIV ما نسوي لها routine amniotomy in order to prevent fetus exposure to such infection. So, usually amniotomy is indicated to further evaluate fetal status. For example, placement of fetal scalp electrodes or uterine contractions. For example, placement of intrauterine pressure catheter. إذا sometimes amniotomy ممكن نحتاجه حتى نشوف الفيتال ستاتس. ممكن نحتاجه بحالة أنه أسوي الانترنال الكترود fetal scalp electrode أو controlling or follow up of the uterine contractions by using an intrauterine pressure catheter. Slower progress in the nulliparous patient is most often the result of inefficient uterine contractions. In the absence of medical contraindication, labor that fails to progress is treated with oxytocin. Monitoring. It is desirable that all examinations be performed by a single individual to minimize inter-observer variation. إذا إحنا دائما نحاول only single one, monitoring the pregnant woman when she is in labor in order to prevent inter-individual variation or inter-observer variation. A vaginal examination during labor often raises anxiety and interrupts the woman's focus, and if there is a premature rupture of membrane, the increasing number of vaginal examinations have been found to be associated with the neonatal sepsis. إذن دائما احنا نحاول يعني as much as possible decrease the number of vaginal examination, especially إذا المother كان عندها أصلا من البداية to prevent neonatal sepsis. ومثل ما قلنا the frequency of vaginal examination as we mentioned before. What are the recommendations on monitoring during the established first stage of labor? Number 1, pictorial records of labor partogram should be used once labor is established. 4 hourly temperature and blood pressure, وإحنا قلنا نقيس vital signs. Hourly pulse. Half hourly documentation of frequency of uterine contractions, and then every half an hour we must check the uterine contractions. A frequent emptying of the bladder. Vaginal examination after 4 hours or when there is concern about the progress, as we mentioned before. Intermittent auscultation of the fetal heart rate after the contractions should occur for at least 1 minute, at least every 15 minutes, and the rate should be recorded as an average. And then what are the recommendations on initial monitoring? Psychological and emotional supports are important. Vital signs, as we mentioned, and urine analysis. Uterine contractions follow-up, as we mentioned it. Abdominal examination with Leopold's maneuver. Vaginal loss, we should assess show or liquor or blood. Vaginal examination when necessary, as we mentioned it. And pain control if we need it, and fetal heart rate monitoring. How can we follow the fetal heart rate during labor? Fetal heart rate assessment has become standard for care for all women in the United States because patient and clinician are reassured by normal results and believe there is some values in detecting abnormal patterns. American College of Obstetrics and Gynecologists suggests that electronic fetal monitoring tracing to be reviewed as follows. Low-risk pregnancy, in the first stage, we must hear the fetal heart every 30 minutes, and in the second stage, every 15 minutes, while in high-risk pregnancy, we must follow the fetal heart rate every 15 minutes in the first stage and every 5 minutes in the second stage. In general, continuous intrapartum fetal heart monitoring is suggested for high-risk pregnancies patient and when fetal heart below 110 or over 160 beats per minute. إذا sometimes إحنا بالهاي ريسك ما نحتاج نسوي لهم الانترميتنت، نحتاج الكونتينوس، والكونتينوس عادة نسوي بالهاي ريسك women as we mentioned it، أو when the fetal heart is abnormal below 110 or over 160 beats per minute. Intermittent auscultation of fetal heart is recommended once a woman is in established active labor. Intermittent auscultation of the fetal heart after a contraction should be continued. Intermittent auscultation can be undertaken by either Doppler ultrasound or Pinard stethoscope. يعني sonic aid and Pinard stethoscope. Uterine contractions monitoring, simple observation of the mother, either simple by observation by the mother, يعني we ask the mother if there is contractions or if there is pain or not, or palpation of the fundus, or by CTG. Direct measurement of intrauterine pressure via internal manometry or pressure transducer. Then these four methods for the assessment of uterine contractions during labor, أما by the mother. يا اما we palpate manually the fundus او we do CTG اللي هو ب two graphs, graph for the uterine contractions and graph for the fetal heart rate variation, or direct measurement عن طريق ال intrauterine catheter. 95% of women in active labor will have 3 to 4 to 5 contractions per 10 minutes, and this is the definition of efficient uterine contractions. We must have more than 3 contractions efficient in per 10 minutes. And this is the partogram. Also the student must know the partogram. The partogram plotted these 4 elements in it اللي هي number 1 maternal status. نشوف ال vital signs, blood pressure, heart rate or pulse rate, ونشوف general urine exam بالإضافة إلى fetal heart rate at the top of the gram. Dilatation and descent, this is plotted on the paragraph. بالإضافة إلى uterine contractions, it is below the paragraph. And we have a postnatal observation or postnatal notes. يعني after delivery you must plot the mode of delivery, we use analgesia or not. This will discuss inshallah بالclinical practice in the clinical sessions. Okay, what is the partogram? It is a graphical representation that clearly shows the patient's labor compared to the expected lower limit of normal progress. Some clinicians employ a partogram with alert and action lines. The alert line represents the rate of dilatation of the slowest 10% of labors and prime gravida. Crossing the alert line suggests that the patient should be transferred to hospital if she is laboring in a rural setting. The action line is parallel and 4 hours to the right of the alert line. Crossing the actions line suggests the need for intervention, for example, either artificial rupture of membrane or administration of oxytocin. This means maybe the contractions is not efficient. And this is the partogram. This is the alert and action line. When the action line is crossed, this means the labor not progressing. That's why we must shifting the patient to the hospital. When it is crossing it, this may be end with cesarean section because the contractions is efficient, but the cervical dilatation and descent is not progressed. هسه دا تلاحظون هاي البيكتشر مال البارتوجرام. هاي هنا الفيتال هارت ريت مونيتورينج، وهنا الامنيوتيك فلو whether it is clear or bloody. C mean clear. شوف هو clear لحد هذه الاريا، وصلنا هنا صار bloody، وهنا تقريبا صار ميكونيوم ستيند لايكر. اوكي، هنا الكونتراكشنز دا تلاحظوها كانت اول شيء خلينا نقول not with good intensity، بعدين صارت very good intensity بحيث صارت يسموها تاكيسيستول. تلاحظوها كل السكوير صارت bolded. This means the contractions is more than efficient, but the progress is not good. It is poor progress. That's why she ended with cesarean section at this time with a live male infant. والويت مالته هم هنا كاتبين تقريبا البوستناتال notes. هذه هنا الأكسيتوسين whether we use it or not with the fluids or not. هاي هنا الظاهر ما مستخدمة لا أكسيتوسين ولا fluids. وهنا الفيتال ساينز فور ذا ماذر، البلاد بريشر والبولس ريت. هنا تلاحظون شوي بدأت تصير يمكن تاكيكارديا. اوكي، وهنا اليورين جنرال يورين اكزام. هنا هم التمبريتشر. اوكي، اذا هو it means the maternal and fetal status during labor. And happy Labor Day, and thank you very much. then we will shift to the continuation of the lecture. We finished the first stage of labor in details, and then we will start with the second stage of labor. The second stage of labor usually lasting about 90 minutes. During this stage, the cervix opens sufficiently and the baby begins to move down the birth canal, and the mother pushes or peers down in response to pressure against her pelvic muscles. The crown of the baby's head becomes visible in the widened birth canal.
Congratulations. You are fully dilated to 10 centimeters. You may now give birth.
As the head emerges entirely left, the physician turns the baby's shoulders right, which emerge one at the time with next contractions, and the rest of the body then slides out relatively easy, and the umbilical cord is sealed and cut. This is the second stage of labor. طبعا second stage of labor أكثر شيء إحنا we show it as a videos rather than lecture, because it has no يعني just events not يعني like encouragement, like observation of uterine contractions, fetal heart, pushing and bearing down, and so on. Then we will shift it to the other parts of the lecture, which is the third stage of labor, its events and management and prophylaxis. طبعا احنا we know the labor is a physiological process, and the products of the conceptions passed from the uterus to outside the outside the world. Normal labor, spontaneous in onset, at term, vertex presentation, natural termination without any complication affecting health of mother and or newborn. And we have 3 stages of labor as we mentioned. The first stage, second stage, and third stage. اللي هو هسه we will discuss it. Third stage, it means after the expulsion of the fetus to the expulsion of the placenta and its membranes. This means after birth. طبعا after expulsion of the fetus to the expulsion of the placenta and membranes, duration يعني average تقريبا 15 minutes in primary and multigravida. يعني تقريبا بالبرايمري والمالتيجرافيدا duration does not differ. بالactive management of third stage of labor, this is the active management of third stage of labor, it's around 5 minutes. It means two parts. It's a placental separation, then placental expulsion. إذا the placenta must be separated, then after that will be expelled. Sudden, how can the placental separation happen or occur? Sudden diminution in uterine size following delivery of the fetus, limited placental elasticity, create disproportion between two placental plaques, placental separation happened, spongy layer of the stua basalis, and there is 2 ways of separation, either central or marginal separation. هذا هو السنترال وهذا هو المارجنال separation. central it is A وهذا هو الثاني هو المارجنال separation. يا اما separated from the central او يبدي المارجن يصير ب separation الى ان يصير complete separation of the placenta. هنا أنا مطينا ال Dukan mechanism بال separation. How can we know there's a separation of the placenta؟ طبعا بالبداية شلون يصير؟ طبعا ورا ما صار separation ايش راح يصير؟ راح يصير expulsion، راح يصير contractions and retraction of the upper uterine segment, placenta forced to the line in the lower uterine segments and upper vagina, voluntary contraction of the abdominal muscles lead to expulsion of the placenta. طبعا راح نرجع هاي signs of the placental separation انه شو يصير blood showing, bleeding happened, زين. والامبلايكال كورد يصير بي lengthening. اوكي. واليوترس يصير more globular الشيب مالته يتغير. بالاضافه احنا when we do a PV examination we sense that the lower part of the placenta will be in the lower segment. These تقريبا 3 or 4 signs for the delivery of the placenta. هو انه يصير gush of blood ويصير lengthening of the cord والبلاسنتا we feel it in the lower segment when do a PV examination, and the fundus will become more globular. What is the mechanism to control the bleeding؟ إذا إحنا عندنا مشكلة لما يصير separation of the placenta، عندنا فد big problem maybe face it، وإن شاء الله راح نجي نحكيها بموضوع postpartum hemorrhage. وعندنا postpartum hemorrhage، فشلون راح يصير control حتى ما يصير هذه البيج أو hazardous problem؟ Number one, there's an effective retraction of the uterine muscles and act as living ligatures, as you see in this picture. When there is a living ligatures act, it will lead to thrombosis of torn sinuses. هاي torn sinuses اللي هي تقريبا صار بيها cut زين ولما صار separation of the placenta. ايش راح يصير لما يصير الليجتشر عليها؟ ايش راح يصير بيها thrombosis. يعني it act as a بالإضافة إلى المyotamponate which is the oppositions of the wall of the uterus. ايش راح يصير both anterior or posterior wall of the uterus ايش راح يصير بيهم؟ راح يصير بيهم opposition تشتغل as a myotamponate حتى to prevent further blood loss، وبالتالي راح يصير controlling of postpartum hemorrhage. بالmanagement of the third stage، طبعا management of the third stage is very important because it is most crucial state. Strict vigilance may need with follow protocol. طبعا عندنا we have two management، عندنا expectant and active management. Expectant management we look for 3 classical signs of placental separations, which is number 1 اللي هسه حكيناها lengthening of the umbilical cord, gush of blood from the vagina signifying separation of the placenta from the uterine wall, and change in the shape of the uterine fundus from discoid to globular with elevation of the fundal height. These are 3 classical signs for the separation of the placenta. We will do this either spontaneous نخلي البلاسنتا spontaneously separated and expelled, or we do a controlled cord traction which is called CCT. Expulsion of the placenta within 20 minutes هاي بحالة السبونتينيوس، وبحالة controlled cord traction will be the time will be less. And in the expectant management we do a massage to the uterus, intramuscular oxytocin or 10 international unit, examination of the placenta and membranes and cord, and an inspection of the vulva, vagina and perineum for any injury. This is the controlled contractions. Left hand palmar surface of the fingers placed above the pubic symphysis, body of the uterus pushed upward and backward like this. Right hand cord traction in down and backward direction like this. Uterus felt hard and contracted. This is the controlled cord traction. إذا إحنا بالexpectant management يا إما نعوفها spontaneous يا إما نسوي لها controlled cord tractions. وتقريبا هو spontaneous يستغرق إيش قد؟ يستغرق 20 minutes. And this is the method on mannequins اللي هي controlled cord traction. When the placenta is observed يعني تكون inside the introitus, the maneuver will be upward forward. فالبداية تكون downward backward. When the placenta will be visible at the introitus, the obstetrician will push the cord upward forward. And after delivery of the placenta, we must examine for the membranes, for the cotyledons, for the cord, in order to see whether there is complete placental delivery or not. This is the examination of the membranes with cord. This is the cord, 2 umbilical arteries and 1 umbilical vein. This is normal. With active management of third stage of labor, we give a prophylactic uterotonic after delivery of the baby. That is to say, oxytocin 10 international units, either in IM. Then after that, cord clamping, cutting, and controlled contractions of the umbilical cord. Then we do a uterine massage. هذا number 1. نعطي اليوتروتونيك للأكسيتوسين، وراها نسوي clamping للكورد، وراها نبدي نسوي controlled contractions، وafter that نبدي بالuterine massage. Exist powerful uterine contractions aid in early placental separation, minimize the blood loss and the duration of the third stage into 5 minutes. And thank you very much.